You know, usually when we talk about a medical diagnosis, there's this expectation of, well, precision, right? Like engineering.
Oh, absolutely.
You break your arm, the x-ray shows that jagged white line, and the attending doctor just points at it and says, there it is.
Right. It's binary. You can see the problem with your own eyes, which is, well, it's comforting.
Yeah, exactly. Both for the patient and the clinician, we like things to be visible, to be perfectly categorized in a neat little box.
But then you step into the world of metabolic bone disease, and suddenly that X-ray machine is often completely useless, at least early on.
It really is. We're looking at a diagnostic landscape that is honestly, it's like trying to read a car's engine health without ever being allowed to open the hood. You're just staring at a dashboard of warning lights, hoping to interpret the flickering.
That is the absolute definition of diagnostic muddy waters. But just like a master mechanic reading a dashboard, if you know exactly what combination of lights means what, the engine tells you precisely what is failing on a cellular level.
And that is exactly what we are doing today. Welcome to this deep dive, specifically tailored for you, the listener, as you prepare for the FRCS Trauma and Orthopedics exam. Think of this as your high-yield audio revision session.
Right, because you might be driving or, doing the dishes, walking the dog, but we are going to lock this material in.
Our mission today is mastering metabolic bone disease and pharmacology. We are pulling directly from FRCS study scripts, elite pharmacology notes, and the core texts. And our entire goal is to map out the classic exam discriminators and, more importantly, the specific traps the examiners love to set for you.
Exactly. And to navigate this entire field, we need to establish the golden rule right up front. If we connect this to the bigger picture, metabolic bone disease is essentially just an exercise in pattern recognition, and is based almost entirely on 4 key blood markers.
Okay, let's unpack this immediately. I want to set the stakes for you right now. Think of this whole module as a detective game. If you can read these 4 numbers, that's calcium, phosphate, parathyroid hormone, and alkaline phosphatase, you can crack almost any case the exam throws at you.
That is the core spine of everything we will discuss today.
I am going to repeat those for you because you need this running in the background of your mind for the rest of this deep dive. The 4 markers are calcium, phosphate, parathyroid hormone, which we'll call PTH, and alkaline phosphatase, or ALP.
Those 4 numbers are your compass. Occasionally, urinary calcium makes a guest appearance as a 5th clue, but if you master the core 4, the diagnosis usually names itself.
So let's jump right into the core framework, specifically looking at the 2 conditions candidates mix up the most on the exam wards. Osteoporosis versus osteomalacia. I mean, they sound like they should be cousins.
They do, yeah. And they both result in weak and fragile bone, which is exactly why they get confused clinically. But functionally and structurally, they are completely different beasts. To understand the difference, we have to look at what bone actually is on a microscopic level.
Right, because it's not just a stick of chalk.
Exactly. Bone is a living composite material. It basically has 2 main components. First, you have the protein matrix, which is mostly typed by collagen. We call this the osteoid.
Okay.
Second, you have the mineral, which is hydroxyapatite, a complex crystal made up of calcium and phosphate.
So if we're building a structure, the collagen osteoid is the flexible steel scaffolding, and the hydroxyapatite mineral is the hard cement poured over it.
That is a perfect analogy.
Yeah.
So with that in mind, let's look at osteoporosis. Osteoporosis is a condition where you have a decreased mass of bone. You have too little bone overall. But, and this is crucial, the bone that remains is perfectly normally mineralized.
Oh, interesting.
Yeah, the ratio of scaffolding to cement is completely normal. You just don't have enough of the total structure.
So osteoporosis is like a structurally sound brick house, but it's just too small. The bricks are fine, the mortar is fine, it's just a miniature house.
Yes. Now, contrast that with osteomalacia. In osteomalacia, you have a completely normal amount of bone matrix, a normal amount of scaffolding, but it is poorly mineralized. The cement was never properly poured or didn't cure right. It is physically soft bone.
So osteomalacia is a full-sized house built exactly to the blueprints, but it's built out of soft, wet clay instead of fired bricks.
Precisely. And this fundamental structural difference dictates exactly what our dashboard of 4 blood markers is going to do. The exam loves to exploit this. In osteoporosis, because the actual mineralization process of the remaining bone is working completely fine, your bloods are beautifully normal.
Wait, really?
Yeah, calcium is normal, phosphate is normal, PTH is normal, alkaline phosphatase is normal. The bloods are incredibly boring.
So if a question describes a patient with fragile bones and multiple fragility fractures, but their calcium, phosphate, PTH, and ALP are all sitting right in the middle of the reference range, I should be thinking osteoporosis. The mineralization machinery is intact.
Correct. But in osteomalacia, the wet clay house, the bloods are screaming that something is deeply wrong with the supply chain.
Right, because if you can't mineralize the bone, it means you're lacking the building blocks.
Exactly. Osteomalacia typically shows a low or normal calcium, a low or normal phosphate, a significantly raised alkaline phosphatase, and a raised PTH.
Okay, wait, let's trace the logic there. Let's explain the why. Why is the parathyroid hormone high?
Because it's a desperate secondary reaction.
Mm.
In osteomalacia, which in adults is most commonly driven by severe chronic vitamin D deficiency, the gut simply cannot absorb dietary calcium. Without active vitamin D, the intestinal doors are locked, so blood calcium inevitably begins to drop.
And the parathyroid glands are basically the body's calcium thermostats.
They are. The parathyroid glands sense this drop in serum calcium, and they panic. They pump out massive amounts of PTH to try and rescue the blood calcium levels. They try to pull calcium from the bone. They tell the kidneys to hold on to calcium and dump phosphate. That physiological panic is secondary hyperparathyroidism.
That makes perfect sense. So the high PTH is just the body's alarm system going off. What about the alkaline phosphatase? Why is the ALP raised?
So alkaline phosphatase is an enzyme produced by osteoblasts, the bone builders. In osteomalacia, these osteoblasts are working overtime. They are frantically laying down the collagen scaffolding, the osteoid, and trying their hardest to mineralize it.
But they can't.
Exactly. They don't have the calcium and phosphate to do the job. So you get this massive accumulation of unmineralized osteoid and hyperactive osteoblasts churning out ALP into the blood.
Okay, here's where it gets really interesting, and here's the exact exam trap you need to watch out for. Because in the real world, and especially in tricky multiple choice questions, these blood profiles can occasionally overlap. You might get an osteoporotic patient with a slightly borderline calcium because they didn't eat well that week.
Right.
Or, an aging patient might have a slightly raised ALP for a completely unrelated reason, like a mild liver issue. The examiner knows this. So the exam will present a muddy clinical picture and ask you for the definitive, absolute distinguishing test between osteoporosis and osteomalacia.
And the answer you must hunt for is the tetracycline-labeled bone biopsy. It is the gold standard separator.
Wait, I really want to lock this in for the listener. If the bloods are ambiguous, the ultimate tiebreaker between osteoporosis and osteomalacia is the tetracycline-labeled bone biopsy.
Yes. That is your undeniable proof.
How does that actually work mechanically? Because it sounds a bit like something out of a forensic science lab.
It is incredibly clever pharmacology. Let's actually look at tetracycline. We normally think of it as an antibiotic used for acne or respiratory infections, but its molecular structure makes it a powerful chelating agent. It literally forms a chemical claw around calcium.
Oh, wow.
So when you administer tetracycline, it circulates in the blood, and the moment it encounters an active site in the body where osteoblasts are currently laying down fresh hydroxyapatite, it grabs on and permanently locks itself into that new bone matrix.
It becomes part of the newly poured cement.
Exactly. And the beautiful quirk of this specific molecule is that under ultraviolet light, it fluoresces. It glows a bright yellow-green. So the diagnostic protocol is this. You give the patient a dose of oral tetracycline. It binds to whatever bone is actively mineralizing that day. You wait a specific precise number of days, usually around 2 weeks. Then you give them a second dose of tetracycline. Finally, a few days later, you take a physical bone biopsy, usually from the iliac crest.
And under the microscope, what are you looking for? 2 glowing lines.
Yes. You put the sample under a fluorescent microscope, and you will see 2 distinct glowing bands. Because you know exactly how many days pass between the 2 doses, you can physically measure the microscopic distance between those 2 fluorescent lines. That distance tells you the exact mathematical rate of bone mineralization.
That is brilliant. So how does this definitively separate our 2 conditions?
Well, think about the pathology we just discussed. In osteoporosis, the mineralization engine itself is working perfectly fine. It's just a smaller engine. So the labels look completely normal. The gap between the 2 fluorescent lines is normal, crisp, and clean. There's just less bone overall on the slide.
The brick house is small, but the bricks are being laid at a normal speed.
Precisely. But in osteomalacia...
The wet clay house...
Right. In osteomalacia, the mineralization process is broken. So the fluorescent labels are grossly abnormal. Mineralization is painfully slow and highly disordered. The fluorescent bands are smeared, they're close together, and you see huge, wide seams of unmineralized osteoid. The raw scaffolding just sitting there waiting for cement that never arrives. So while blood tests can hint at the diagnosis, the tetracycline double label is the ultimate, undeniable separator.
Let me state that for you one more time. The definitive test is the tetracycline-labeled bone biopsy. Okay, if you only remember one thing from this entire discussion on bone structure, osteoporosis is less bone with normal bloods, osteomalacia is soft, undermineralized bone, and the definitive test that separates them is the tetracycline-labeled biopsy.
A perfect synthesis. Now that we understand how the dashboard lights can distinguish these structural bone density issues, we need to shift our focus. We need to explore what happens when the parathyroid gland itself, the master thermostat, malfunctions and drives these blood numbers completely off a cliff.
Right, let's decode the calcium panel. Let's really map out this interpretation grid.
Let's start at the bottom. Hypoparathyroidism. Let's look at true hypoparathyroidism first. This means the parathyroid glands have fundamentally failed, or much more commonly in surgical practice, they've been accidentally damaged or removed during a thyroidectomy. The factory is closed. There's no PTH being made.
So tracing the physiology. Normally, PTH acts to raise blood calcium by pulling it from bone and gut, and it tells the kidneys to dump phosphate into the urine. If PTH is suddenly gone, that entire system inverts.
Exactly. Without the PTH signal, calcium plummets and phosphate is hoarded by the kidneys, so it clings. Therefore, the classic exam pattern for true parathyroid failure is low PTH, low calcium, high phosphate.
Just to echo that for our listeners, because it's the foundation of the trap we're about to spring, true hypoparathyroidism is low PTH, low calcium, high phosphate. Let me say it again for you. Low PTH, low calcium, high phosphate.
The examiners rarely just ask you about a straightforward surgical complication. They wonder if you can spot the imposter. They want to test you on pseudo-hypoparathyroidism.
Pseudo-hypoparathyroidism. Even the name is intimidating.
It is, but the pathophysiology is an absolutely brilliant piece of biology. In pseudo-hypoparathyroidism, the parathyroid glands are perfectly healthy. The factory is fully operational. But the target tissues, specifically the kidneys and the bones, have a genetic mutation. Specifically, it is a defect in the G-alpha protein receptor mechanism. They have profound receptor-level resistance to the hormone.
Okay, let's break down that jargon. What is a G-alpha protein?
Think of it as the internal cellular messenger. When PTH arrives at a kidney cell, it binds to a receptor on the outside surface. But that receptor can't just magically alter the cell's behavior. It has to trigger a domino effect inside the cell. That first domino is the G-alpha protein. It's a molecular switch. Once activated, it travels along the inside of the cell membrane and turns on an enzyme called adenylate cyclase, which ultimately changes what the kidney cell does with calcium and phosphate.
So in pseudo-hypoparathyroidism, the mutation physically breaks that internal switch. The hormone binds to the outside of the cell perfectly fine, but the G-alpha protein is jammed. The domino doesn't fall.
That is exactly it.
I picture this as the parathyroid gland shouting into a disconnected phone line. The gland is screaming, raise the calcium, dump the phosphate. But the kidneys literally cannot hear the signal because the wire is cut.
That is the perfect analogy.
Yeah.
And because the tissues cannot hear the signal, the resulting blood chemistry looks absolutely identical to true hypoparathyroidism. The calcium falls and the phosphate climbs. You get low calcium and a high phosphate. And the urinary calcium is also reduced because the kidney isn't absorbing it.
Yeah.
But here is the massive, critical discriminator for the exam. What is the actual PTH level doing in the blood?
Well, if the gland is healthy and it's screaming into a disconnected phone because the calcium is low, it's going to shout even louder. So the PTH level in the blood must be normal or high.
Precisely. The PTH is normal or elevated. So let's put it together. The calcium and phosphate are identically deranged, low calcium, high phosphate, in both true and pseudo-hypoparathyroidism. The only way to spot the pseudo trap on a lab panel is to look straight at the PTH level.
So if I'm looking at a multiple choice question and the clinical vignette shows low calcium and high phosphate, my eyes need to dart immediately to the PTH value. A low PTH means true hypoparathyroidism. A normal or high PTH means pseudo-hypoparathyroidism.
You've got it completely. It's a pure test of understanding the feedback loop.
All right, let's flip the script. Let's look at the hyperparathyroid breakdown. What happens when there is way too much PTH in the system? The textbooks divide this into 3 flavors: primary, secondary, and tertiary.
Let's start with primary hyperparathyroidism. This is when a rogue gland just goes completely autonomous. Usually it's a single benign parathyroid adenoma that ignores all negative feedback and just pumps out PTH uncontrollably.
So because the PTH is artificially high, it drags the calcium up from the bones and gut and violently dumps the phosphate through the kidney. So primary is high calcium, low phosphate, high PTH.
Correct. Now, secondary hyperparathyroidism we actually touched on earlier when we discussed osteomalacia.
Right, the desperate panic response.
Exactly. Secondary is an appropriate physiological glandular response to a chronically low blood calcium environment. Most commonly, you see this in chronic kidney disease, where the kidneys can no longer activate vitamin D or excrete phosphate, or in severe nutritional vitamin D deficiency. The serum calcium is chronically low, or scraping the bottom of normal, so all 4 parathyroid glands hypertrophy. They physically grow larger and pump out massive amounts of PTH to compensate.
So in secondary, the hallmark is low or normal calcium with a significantly high PTH.
Yes, which brings us to tertiary hyperparathyroidism. Tertiary is essentially what happens when secondary goes on for far too long.
How does that happen?
Imagine a patient who has been on dialysis for chronic kidney disease for 10 years. Those parathyroid glands have been constantly, relentlessly stimulated to produce PTH for a decade. Eventually, they undergo nodular hyperplasia. The tissue physically changes and becomes completely autonomous. The glands essentially forget how to switch off. Even if you somehow fix the underlying kidney disease or give them a renal transplant, the parathyroid glands keep aggressively pumping out PTH.
So they've transformed from a secondary reaction into a primary-like rogue state, which means they are now actively driving the calcium levels dangerously high.
Exactly. So the blood profile for tertiary hyperparathyroidism is high calcium and a massively high PTH.
Okay, let's crystallize this for the candidate. If you only remember one thing from this deep dive into the interpretation grid, low calcium plus high phosphate is always the parathyroid failure picture. The PTH level is your only key to tell if it's true failure, meaning a low PTH, or pseudo-failure, meaning a normal or high PTH.
That is the essential takeaway. Lock that in.
Moving forward, speaking of low calcium and high PTH, that specific combination is the classic textbook presentation of nutritional rickets in children. But the FRCS syllabus makes it very clear. They don't just want you to know about nutritional deficiency. They expect you to understand a completely different, genetically distinct variant.
Yes, they do. While nutritional rickets is fundamentally a lack of vitamin D, the exam heavily tests a condition called hypophosphatemic rickets.
Hypophosphatemic rickets.
This condition is not a calcium absorption problem. It is fundamentally a renal phosphate wasting disorder. The kidneys are inappropriately leaking massive amounts of phosphate into the urine.
Why does the kidney do that? What's the mechanism?
It's driven by a hormonal defect, usually involving an overproduction or reduced degradation of a hormone called FGF23 fibroblast growth factor 23. FGF23 is a hormone produced by bone cells that normally tells the kidney to excrete phosphate. In this genetic condition, there's far too much FGF23 activity. So the kidneys just open the floodgates and dump phosphate into the urine.
And because the phosphate is being relentlessly drained away, the bone doesn't have the critical hydroxyapatite building blocks, and mineralization fails, leading to the Rickets phenotype, the bowing of the legs, the widened growth plates.
Exactly. The skeletal outcome looks like nutritional rickets, but the biochemical engine driving it is entirely different.
So what does the dashboard look like for this condition? What are the key numbers?
The absolute standout number on the blood panel is a profoundly low phosphate. And crucially, because this isn't a gut absorption issue, the serum calcium is usually completely normal. Let me emphasize that pattern. In hypophosphatemic rickets, you are hunting for a low phosphate, usually paired with a completely normal calcium.
Let me make sure you get that, listeners. Low phosphate with normal calcium. I'll say it twice. Low phosphate, normal calcium. Okay, so it's an isolated phosphate wasting problem. But why is this so heavily tested? Is it just because of the FGF23 pathway?
It's tested heavily because it contains the ultimate genetics trap. In orthopedics, genetic inheritance patterns can all start to blur together. Most skeletal dysplasias are autosomal dominant. Many metabolic conditions are autosomal recessive. And a few famous ones like Duchenne muscular dystrophy or hemophilia are X-linked recessive. But hypophosphatemic rickets is a pure high-yield recall mark because it is the single major skeletal condition candidates are expected to know that is X-linked dominant.
Let me state that again loud and clear for the listeners. It is X-linked dominant. Hypophosphatemic rickets is the classic X-linked dominant condition. One more time. X-linked dominant.
It is genuinely rare to see an X-linked dominant inheritance pattern in this specific field. If you get a multiple choice question asking which condition out of a list is X-linked dominant and hypophosphatemic rickets is sitting there as option C, you click it and move on. That is your answer.
I love a good spoken mnemonic to anchor these rare facts. Just remember this hook. X marks the spot where the phosphate drains away. X marks the spot where the phosphate drains away.
That's a highly effective way to anchor it to both the genetics and the pathology.
So if you only remember one thing from this segment, hyperphosphatemic rickets is fundamentally renal phosphate wasting. So look for the low phosphate on the blood panel and know that it is the quintessential X-linked dominant condition.
Excellent. We've covered a tremendous amount of ground on these systemic whole-body hormone issues. It's probably a good time for a quick consolidation before we change gears.
Absolutely. Before we move from systemic issues to localized, bizarre bone diseases, let's weave in our first mid-dive consolidation. Let's mentally synthesize the crucial discriminators from this first half. I will set up the clinical scenario, and you give us the definitive takeaway.
Let's do it.
Number 1. We have a patient with fragile bones. We need to distinguish between osteoporosis and osteomalacia, but the bloods are ambiguous.
Osteoporosis is a low mass of normally mineralized bone. Osteomalacia is a normal mass of soft, unmineralized bone. When the bloods fail you, they are separated definitively by the tetracycline-labeled bone biopsy. We'll confirm that again. The ultimate tiebreaker is the tetracycline-labeled bone biopsy.
Perfect. Number 2, we have a patient panel showing parathyroid failure.
The baseline for parathyroid failure is low calcium and high phosphate.
Yeah.
If the PTH is low, it is true hypoparathyroidism. The gland is dead. If the PTH is normal or high, it is pseudo-hypoparathyroidism. The gland is working, but the G-alpha-protein receptor switch is broken. To reiterate, low PTH is true failure. Normal or high PTH is pseudo. I'll say that twice too. Low PTH is true failure.
Yeah.
Normal or high PTH is pseudo.
Number 3, a child with bowing legs but normal calcium.
That points to hypophosphatemic rickets. It presents with a low phosphate due to renal wasting, and critically, it is an X-linked dominant condition. Let me repeat the genetics. It is an X-linked dominant condition. Remember the hook. X marks the spot where the phosphate drains away.
Boom. Locked in. All right, moving on. Up until now, we've seen what happens when mineralization fails globally across the entire skeletal system. But what happens when the bone remodeling process itself just goes completely localized frantic? I'm talking about Pagets disease of bone.
Pagets disease is absolutely fascinating pathophysiology. To understand it, you have to understand normal bone remodeling. Normally, your bone undergoes a highly coupled, highly synchronized remodeling process. It's an elegant dance. Osteoclasts, which resorb bone, dig a microscopic trench. Then osteoblasts follow right behind them and meticulously fill that trench with beautiful, structurally sound, organized lamellar bone. In Pagets disease, that coupling goes entirely haywire.
I always picture this as a construction site where the foreman has completely lost his mind.
That's a terrifyingly accurate analogy. What happens in a pagetic lesion is you get a massive, frantic initial wave of osteoclast resorption. These giant, hyperactive, multinucleated osteoclasts start tearing down the existing bone at an incredible speed. And then the osteoblasts realize what's happening. They rush in, panicked, and they try to lay down new bone far too quickly to fill the massive voids. Because they are rushing, they don't have time to lay down organized lamellar bone. Instead, they lay down chaotic, disorganized woven bone.
It's like pouring quick, dry cement haphazardly just to fill a hole. So the end result is a bone that is technically bigger, and on an X-ray it actually looks thicker and denser, but structurally it's terrible.
Exactly. It's thick, but it's brittle and weak. Because the collagen fibers are entirely disorganized, the bone is highly prone to bowing deformities under weight, and it's highly susceptible to pathological fractures.
Now, the pathology textbooks break Pagets down into 3 distinct phases. The exam loves sequencing questions. Can we walk through those?
Certainly. The pathology moves through 3 defined stages. First is the lytic phase, also known as the osteoclastic phase. This is where the hyperactive osteoclasts are just carrying everything down, creating large, loosened areas on an X-ray. Second is the mixed phase, where both the osteoclasts are still destroying and the osteoblasts are hyperactive, frantically building woven bone. Third is the sclerotic phase. In this final stage, the osteoclast activity burns out, and you're left with dense, disorganized, heavily sclerotic woven bone that looks thick but is mechanically inferior.
So the sequence to memorize is lytic, mixed, sclerotic. I'll echo that for the listener. Lytic first, then mixed, then sclerotic. One more time for good measure. Lytic, mixed, sclerotic. Now, returning to our dashboard of 4 blood markers, where does Pagets sit?
Pagets gives you a beautifully clean, highly testable exam pattern. Because this frantic activity is localized to specific bones, maybe just the skull, the pelvis, or one femur, the overall systemic calcium and phosphate levels remain completely normal. The body's homeostasis handles the local calcium flux. But because the osteoblasts in that specific area are working at such a frantic, accelerated pace, they release massive amounts of alkaline phosphatase into the bloodstream.
So it's not a global derangement, it's an isolated spike.
Yes. Paget's disease classically presents with an isolated raised alkaline phosphatase with entirely normal calcium and phosphate. And this isolated raised ALP is not just diagnostic, it is the exact serum marker we use clinically to monitor disease activity and see if our pharmacological treatments are actually working.
Let's talk about the clinical complications and the specific exam traps, because Pagets is absolutely full of them. What is the quiz favorite? What do they love to ask about?
The absolute quiz favorite involves the skull. When Pagets aggressively attacks the skull base, that chaotic woven bone is physically soft compared to normal lamellar bone. It simply cannot support the weight of the cranium sitting on the cervical spine. So over time, the skull base softens, flattens, and the skull literally sinks down onto the cervical spine.
That sounds terrifying. It creates a very specific visual clinical sign, right?
Yes, clinically, the patient appears to have lost neck length. It creates what textbooks call a short neck appearance. But the trap is the vocabulary. The exam will describe an elderly Pagets patient with a suddenly short neck or an altered head carriage, and the multiple-choice distractors will offer very tempting, plausible-sounding answers like cervical kyphosis or osteoporotic vertebral crush fracture. You have to ignore those. The exact exam vocabulary word you must hunt for is platybasia.
Platybasia.
I'll say it again to lock it in. The short neck appearance caused by the skull sinking is platybasia. I'll repeat that, platybasia. And it is clinically dangerous because as the skull base flattens, it can progress to basilar invagination, where the odontoid peg of the second cervical vertebra projects upward and compresses the brainstem.
So if the question stem describes a Pagets patient with a suddenly short neck, I shouldn't jump to kyphosis or a spine fracture. The exact word I need to hunt for in the answers is platybasia. Now, what are the other high-yield, Viva-ready complications we need to have in our back pocket for Pagets?
You need to understand the mechanism for high-output cardiac failure. Pagetic bone is incredibly vascular. Because the remodeling is so frantic, it requires massive blood flow. The bone acts almost like an enormous arteriovenous shunt, demanding so much circulation that it forces the heart to pump much, much harder, eventually leading to high-output failure.
Wow, so the bone is literally stealing the cardiovascular reserve. What else?
You need to know about nerve compression. Because the bones get thicker, they narrow the bony foramina where nerves exit. The classic example is the temporal bone thickening and compressing the 8th cranial nerve, leading to profound deafness. You also need to know about the severe bowing deformities, like the classic saber tibia and pathological fractures.
And the most dangerous complication, the red flag.
Sarcomatous transformation, Paget sarcoma. It happens in less than 1% of patients, but it is highly aggressive and usually lethal. The classic clinical red flag you must recognize is a patient with known, long-standing, stable Paget's disease who suddenly develops a new, severe, unrelenting pain in a previously asymptomatic Pagetic bone. A sudden change in symptoms means you must suspect Paget sarcoma until proven otherwise.
Okay, if you only remember one thing from this deep dive into Pagets, it is a disease of disordered, chaotic remodeling characterized by an isolated high alkaline phosphatase, and the classic short neck skull deformity is called platybasia.
Moving right along. We just noted that Paget's has normally regulated calcium. But what if we encounter a distinctly high calcium on the wards or in a multiple-choice question? We need to list the culprits of hypercalcaemia and flag the biggest trap of the entire module.
This is crucial because hypercalcaemia is a medical emergency. What are the heavy hitters? If I see a high calcium, what are the most common causes I should think of first?
In a clinical setting, over 90% of hypercalcaemia cases come down to two major causes. The first is primary hyperparathyroidism, which we discussed, the rogue adenoma pumping out PTH. The second, and often more sinister, is malignancy.
How exactly does cancer cause hypercalcaemia?
Malignancy can drive hypercalcaemia through several distinct mechanisms. You can have hematological cancers like multiple myeloma, which activate osteoclasts locally. You can have solid tumors, like breast or lung cancer, that send direct bony metastases to the skeleton, physically destroying the bone and releasing calcium. Or you can have a paraneoplastic syndrome, where solid tumors, classically squamous cell lung carcinomas, secrete a hormone called PTH-related peptide, or PTHrP. This peptide structurally mimics true PTH and fools the kidneys and bones into releasing massive amounts of calcium.
So primary hyperparathyroidism and malignancy are the top two. What are some of the other less common causes that might show up in a which of the following causes hypercalcemia list?
You might see vitamin D toxicity, where massive oversupplementation drives pure gut absorption. You will frequently see granulomatous diseases, particularly sarcoidosis.
Let's explain that one because sarcoidosis isn't a bone disease. How does it cause high calcium?
It's a fascinating mechanism. The granulomas in sarcoidosis are packed with macrophages, and these specific macrophages abnormally express an enzyme called 1-alpha hydroxylase. This is the exact enzyme the kidney normally uses to activate vitamin D. So the sarcoid granulomas act like rogue kidneys, converting immense amounts of vitamin D into its active form independently of normal regulatory feedback, which then drives hypercalcemia from the gut.
That is wild. Okay, what else is on the list?
Thyrotoxicosis can increase bone turnover. We already mentioned tertiary hyperparathyroidism. Prolonged immobilization, like a patient in a full-body cast for months, removes the mechanical stress from bones, causing osteoclasts to outpace osteoblasts and dump calcium. And finally, medications, most notably thiazide diuretics.
Let's quickly trace the mechanism for thiazides because I know that's a pharmacology favorite. Why do they cause high calcium?
Thiazides work in the distal convoluted tubule of the kidney. They block the sodium chloride symporter, which stops sodium from being reabsorbed. So water follows the sodium out into the urine, which gives you the diuretic effect. But because the kidney cell is now suddenly starving for intracellular sodium, it kicks another pump into overdrive on the basolateral side, the blood side of the cell. This pump trades sodium for calcium. So to get sodium back, the cell violently pulls calcium out of the forming urine and dumps it back into the bloodstream. You lose sodium, but you hoard calcium, leading to hypercalcemia.
Okay, so we have our list of genuine causes: primary hyperparathyroidism, malignancy, sarcoidosis, thiazides. Here is where the examiner sets the trap.
Yes, the classic exam trap. The multiple choice question will ask you to identify the cause of hypercalcemia from a list. It will list things like myeloma, sarcoidosis, thyrotoxicosis, and it will slip the word bisphosphonates into the list. Bisphosphonates are the odd one out.
Why do candidates fall for this?
Because candidates associate the word bisphosphonate with calcium metabolism, and under exam stress, they assume it causes the derangement. But bisphosphonates are a powerful treatment for acute hypercalcemia. They poison osteoclasts, which stops them from breaking down bone, which stops the flood of calcium into the blood. They do not, under any circumstances, cause hypercalcemia.
Let me echo that for ultimate clarity. Bisphosphonates are used to treat acute hypercalcemia. They do not cause it. Let me repeat that one more time. Bisphosphonates treat acute hypercalcemia. They do not cause it. They lower calcium.
Exactly. So if you're doing a rapid-fire check during the exam and you see bisphosphonates sitting in a list of things that purportedly cause high calcium, you cross it out immediately. It's the firefighter, not the arsonist.
I love that. The firefighter, not the arsonist. If you only remember one thing for this section, the major hypercalcemia causes are hyperparathyroidism and malignancy, and bisphosphonates are the treatment for high calcium. They never cause it.
Which brings us nicely to our second mid-dive consolidation. Let's briefly synthesize these structural diseases and hypercalcemia rules before we transition fully into the pharmacology of how we actually treat these conditions.
Okay, let's walk the mental words again. Number one, an elderly patient presents with a bowing tibia, isolated high alkaline phosphatase, and they recently had to buy larger hats because their skull is enlarging.
That is the classic presentation of Pagets' disease-disordered chaotic remodeling. And remember, if that patient's skull begins to sink, causing a short neck appearance, the exact clinical term is platybasia. I'll state it twice. Isolated high ALP and a short neck is platybasia.
Number two, you are looking at a blood panel with a severely elevated calcium level.
Your immediate differential diagnosis must be led by primary hyperparathyroidism and malignancy. I'll say that twice for you. Hyperparathyroidism and malignancy lead the list.
Number three, you are prescribing a bisphosphonate to a patient.
You are prescribing it to shut down osteoclasts and stop bone resorption. Therefore, bisphosphonates treat high calcium, they never cause it. I will reiterate, bisphosphonates treat high calcium, never cause it.
Perfect. All right, let's transition into pharmacology proper. We just mentioned bisphosphonates as a treatment. One of their absolute most critical use cases in orthopedics and rheumatology is preventing the devastating bone damage caused by long-term steroids. So let's unpack this. How exactly do steroids wreck bone?
Glucocorticoid-induced osteoporosis is arguably the most common secondary cause of osteoporosis we see. It's a dual-pronged attack, which makes steroids uniquely devastating to the skeleton over the long term. There is an indirect systemic mechanism and a profoundly direct cellular mechanism.
Let's start with the systemic indirect hit. How do steroids mess with the calcium supply?
Indirectly, glucocorticoids severely interfere with how the body handles calcium. They act on the gut to significantly reduce the intestinal absorption of dietary calcium. Simultaneously, they act on the kidneys to decrease tubular reabsorption, increasing the loss of calcium directly into the urine.
So you have less calcium coming in through the front door and more calcium being thrown out the back door. The inevitable result is that serum calcium starts to drop.
Precisely. And as we've established, what happens when serum calcium drops? The parathyroid glands react. They sense the impending hypocalcaemia and secrete more PTH to try and rescue the blood calcium levels by pulling it directly out of the skeletal vault.
Wait, let me push back on this physiology for a second because this feels like a trap. Are you saying steroids cause secondary hyperparathyroidism? That's totally counterintuitive to me. I've always thought of steroids as immunosuppressants that just paralyze the bone-building cells, not drugs that trigger a whole secondary hormonal cascade to actively strip the bone.
It is entirely counterintuitive, which is exactly why examiners love it. It is a classic exam false statement trap. A multiple-choice question will ask which statement regarding glucocorticoid osteoporosis is false, and it will offer the claim. Steroids do not cause secondary hyperparathyroidism. That is the false statement, because they absolutely do.
Let me reiterate that for the listener, because it's so easy to get backwards. Steroids absolutely cause secondary hyperparathyroidism as a compensatory reaction to the calcium loss. Hear it twice, you guys. Steroids cause secondary hyperparathyroidism.
That is correct. So that's the indirect hit. PTH is actively stripping the bone, but the direct mechanism is arguably worse.
What do steroids do directly to the bone cells?
Steroids are profoundly, fundamentally toxic to osteoblasts, the bone-building cells. They suppress osteoblast differentiation and function. But even more devastatingly, they actively push mature osteoblasts and the osteocytes embedded deep within the bone matrix into premature apoptosis, which is programmed cell death. So the entire bone formation process just grinds to a complete dead halt.
So you have elevated PTH aggressively tearing the bone down on one side, and all the bone builders committing cellular suicide on the other side. It's a perfect storm for rapid bone loss.
Exactly. And the clinical impact of this storm is anatomically specific. Glucocorticoids preferentially attack trabecular bone over cortical bone.
Trabecular bone being the spongy, honeycomb-like bone found inside the hard outer shell.
Yes. Places like the vertebral bodies are incredibly rich in trabecular bone, which has a very high surface area and turnover rate. This is why the classic devastating clinical presentation of steroid-induced osteoporosis is a patient suffering incredibly painful, spontaneous vertebral crush fractures. And you need to know for the exam that this bone loss is not slow and gradual. It is steepest and fastest in the very first 6 to 12 months of starting steroid therapy.
Which means as a clinician, you cannot afford to wait and see.
Correct. Prevention is paramount. This is why guidelines dictate that patients going on long-term systemic steroids, like for polymyalgia rheumatica or severe asthma, are often immediately co-prescribed bisphosphonates alongside calcium and vitamin D supplementation to protect the skeleton before the damage occurs.
Okay, if you only remember one thing from this section on steroids. Steroids cause osteoporosis by dropping gut calcium and raising urinary calcium, which unexpectedly triggers secondary hyperparathyroidism while directly suppressing and killing osteoblasts, hitting the trabecular bone of the spine the hardest.
Which perfectly sets up our deep dive into the pharmacology of bisphosphonates. We've talked about them as the ultimate firefighters, the heroes of the steroid story, and the hypercalcaemia story. Now, the exam expects us to know exactly how they work on a molecular level to shut down osteoclasts.
Let's get under the hood. What is the actual biochemistry here?
The basic targeting mechanism is actually quite elegant. Bisphosphonates are synthetic analogs of inorganic pyrophosphate. Because of their molecular structure, they have an incredibly high chemical affinity for hydroxyapatite, the mineral crystal of bone. So when you administer an IV infusion of zoldrodronate or a patient swallows an alendronate tablet, the drug travels through the blood and binds directly and tightly to the exposed mineral surface of the bone, particularly at sites where bone remodeling is actively happening.
So the drug just paints the surface of the bone and sits there?
Yes. It lies in wait until an osteoclast arrives to do its job. The osteoclast attaches to the bone, creates a sealed acidic microenvironment to dissolve the mineral, and in the process of dissolving the bone, it unwittingly swallows the bisphosphonate drug.
It's literally a molecular Trojan horse. The osteoclast eats the bone, swallows the drug, and then gets poisoned from the inside out.
That is a perfect analogy. But the FRCS examiner wants to know how it gets poisoned. What is the lethal mechanism? And this completely depends on which generation of bisphosphonate we are talking about.
Okay, let's look at the modern powerful ones first.
The modern ones are the nitrogen-containing bisphosphonates. These are your heavy hitters, drugs like alendronate, risdronate, and zolidronate. Once internalized inside the osteoclast, these specifically target and block a crucial enzyme called farnesyl pyrophosphate synthase, which is a key bottleneck in the mevalonate pathway.
Farnesyl pyrophosphate synthase in the mevalonate pathway. That sounds like a terrifying biochemistry flashback. We need to break that down.
It is biochemistry, but it's highly testable. Let's demystify it. The mevalonate pathway is famous mostly because it's the pathway our bodies use to synthesize cholesterol in the liver. It's the exact pathway that statin drugs target. But cholesterol isn't the only product of this pathway. It also produces critical little lipid molecules called isoprenoids, specifically farnesyl groups.
Okay, what does a farnes group actually do for an osteoclast? Why does blocking it kill the cell?
Think about the physical job of an osteoclast. It's a massive cell that has to lash onto bone tightly, forming a sealed suction cup, and then it has to violently ruffle its membrane to secrete acid. To do that mechanical work, it needs a highly complex, dynamic internal cytoskeleton. The cell builds that internal scaffolding using signaling proteins like RAS and Rho. But for those proteins to work, they must be physically anchored to the inside of the cell membrane.
And how do they anchor?
The cell takes those lipid farnesyl groups and basically superglues them to the proteins, creating a fat-soluble tail that sticks directly into the lipid cell membrane. This anchoring process is called farnesylation. So if your bisphosphonate blocks farnesyl pyrophosphate synthase, there are no farnesyl tails produced.
The proteins can't anchor to the membrane.
Exactly. The signaling proteins float away uselessly. The internal scaffolding of the cell collapses. The suction cup detaches from the bone, the osteoclast completely loses its ruffled border, and unable to function, the cell literally undergoes apoptosis. It dies.
That is fascinating. The scaffolding collapses from the inside. I will state those key terms again for the listener because you will see them in multiple choice options. Nitrogen-containing bisphosphonates block farnesyl pyrophosphate synthase in the mevalonate pathway. Let me repeat it twice.
Yeah.
Block farnesyl pyrophosphate synthase in the mevalonate pathway. What about the older drugs?
The older, first-generation non-nitrogen bisphosphonates, like etidronate or clodronate, work via a completely different mechanism. They don't block the mevalonate pathway at all. Instead, because they look structurally similar to pyrophosphate, they get mistakenly incorporated into the cell's energy system. The osteoclast builds them into a toxic, non-functional analog of ATP.
And ATP is the energy currency of the cell.
Right. So by creating fake ATP, they essentially bankrupt the cell's energy stores, starving the osteoclast to death.
Different molecular weapon, same dead osteoclast. Now, we absolutely cannot talk about pharmacology without talking about side effects. Examiners love side effects. What are the major red flags the exam looks for with bisphosphonates?
There are three main side effects you must know cold. First, esophagitis. Oral bisphosphonates are notoriously irritating to the esophageal lining. This is why patients are strictly instructed to take the pill upright on an empty stomach with a full glass of plain water, and they must remain completely standing or sitting upright for at least 30 minutes.
Because if they swallow it and immediately lie back down in bed, it refluxes, sits in the esophagus, and causes severe chemical burns. Got it. What's the second?
Second is a rare but devastating complication. Osteonecrosis of the jaw, commonly abbreviated as ONJ. This is where the jawbone literally dies and becomes exposed. It most frequently presents in cancer patients who are receiving massive doses of intravenous bisphosphonates, often triggered shortly after a dental extraction or jaw surgery.
The bone can't heal the extraction socket because the osteoclasts are totally paralyzed. And the third side effect?
The third is deeply paradoxical and heavily tested. Atypical femoral fractures. These occur specifically with very long-term bisphosphonate use, usually over 5 years. Because the drugs have profoundly frozen the normal remodeling process, the bone cannot repair the microscopic wear and tear microcracks that naturally occur from walking. Over years, this microdamage accumulates. Eventually, this leads to a very specific, spontaneous transverse fracture on the lateral cortex of the subtroenteric femur, often starting with a small beak or thickened area of cortical hypertrophy.
So, a drug designed to prevent fractures eventually causes a highly specific type of fracture if used too long. Let me confirm those three side effects for the listeners making mental notes. You need to watch out for esophagitis, osteonecrosis of the jaw, and atypical femoral fractures. I will say them twice. esophagitis, osteonecrosis of the jaw, and atypical femoral fractures.
Excellent summary.
If you only remember one thing from this dense pharmacology section, bisphosphonates bind to hydroxyapatite and act as a Trojan horse to poison osteoclasts. The modern nitrogen-containing ones specifically do this by blocking farnesyl pyrophosphate synthase in the mevalonate pathway.
That brings us to our final core topic, osteonecrosis, which we also casually call dead bone or avascular necrosis. We just mentioned osteonecrosis of the jaw as a drug side effect, but this is a massive topic in the trauma syllabus. We need to look at what actually happens histologically when a bone loses its blood supply entirely.
I'm thinking of a classic orthopedic scenario, a displaced intracapsular fracture of the femoral neck. The delicate retinacular blood vessels supplying the femoral head are torn. The bone is suddenly completely cut off from its oxygen supply.
Right. And we have to remember, bone tissue is not just inert rock. It is highly metabolically active. Without oxygen, the cells living inside the bone matrix, the osteocytes, start to suffocate and die very rapidly, usually after just 12 to 48 hours of profound ischemia.
So let's say I'm an examiner. I present a case where a patient had a displaced femoral neck fracture. We remove that dead femoral head during a hip replacement a week later and look at it under a microscope or on an X-ray. What do I see?
That is the ultimate exam catch. If you look at the mineralized architecture of the bone itself, the hydroxyapatite scaffolding, it looks completely 100% normal at first. The calcium and phosphate matrix doesn't just evaporate into thin air just because the cells living inside it died. It remains a rigid, hard scaffold. The structural collapse and flattening you eventually see on a late-stage X-ray happens months later when the body attempts a doomed repair process and mechanically weakens the structure.
Okay, so if the hard bone matrix looks totally normal early on, what is the ultimate discriminating detail? If the multiple choice question asks for the very first, earliest histological sign of bone death under a microscope, I shouldn't be looking at the hard bone trabeculae at all, should I?
No, you absolutely should not. The absolute earliest histological changes happen in the marrow spaces, situated directly between the bone trabeculae, not in the hard bone itself. The bone marrow is highly cellular, highly vascular, and incredibly sensitive to ischemia.
So I'm looking at the marrow fat.
Exactly. You are looking specifically for the necrosis of marrow fat. Normally, under a microscope, healthy fat cells look like clear, distinct bubbles with sharp outlines. When they suffer ischemic death, those sharp cell membranes break down or rupture, and the lipid content spills out. It just looks like an amorphous, soapy, pink sludge. That loss of fat cell outlines is the absolute first sign. The second early sign is the appearance of incoming tissue histiocyte scavenger macrophages, rushing in from the viable periphery to try and clean up the dead marrow tissue.
What about the empty osteocyte lacunae? I remember reading about ghost cells, the little microscopic caves where the bone cells live being empty.
The empty lacunae, or ghost cells, are indeed a classic textbook hallmark of dead bone. But they happen much later in the timeline. The osteocyte has to die, and then its nucleus and all its cellular material have to completely undergo autolysis and dissolve away before the lacunae actually appears visibly empty under the microscope.
Yeah.
That takes significant time. The marrow fat changes happen first.
So to cement that for the listener, the earliest histological signs of bone death are the loss of fat cell outlines in the marrow, followed by the appearance of incoming tissue histiocytes. Let me say that twice for you guys. Earliest signs are a loss of fat cell outlines and incoming histiocytes.
Spot on. Now, once a segment of bone is definitively dead, how does the body attempt to fix it?
It tries to rebuild, right, through a process called creeping substitution.
Yes, creeping substitution. It's a fascinating but flawed physiological rescue mission. New, living blood vessels slowly crawl from the healthy, viable bone into the dead ischemic area. Along with these vessels come osteoclasts and osteoblasts. The osteoclasts act as the demolition crew, slowly tearing down the dead, necrotic hydroxyapatite scaffolding. And the osteoblasts follow right behind, laying down new living bone over top of the remnants of the dead bone.
But there's a massive mechanical vulnerability built into that process, isn't there?
A catastrophic one. Creeping substitution is agonizingly, painfully slow. And structurally, because the osteoclasts have to actively drill into and remove the dead bone before the osteoblasts can lay down new bone, the overall area actually becomes significantly structurally weaker before it becomes stronger. If this process is happening in a major weight-bearing joint, like the femoral head and the hip, the mechanical stress of walking will cause the weakened, actively repairing subchondral segment to mechanically collapse and flatten entirely. That structural collapse is the tragedy of a vascular necrosis of the hip, leading to rapid, severe osteoarthritis.
If you only remember one thing from the section on dead bone looks structurally normal at first. The absolute earliest histological signs of ischemia are found in the marrow, specifically the loss of fat cell outlines and the arrival of incoming histiocytes.
We have successfully covered the entire metabolic and pharmacological matrix. It is time to lock it down permanently for the candidate.
Yes, it is. We are entering the final consolidation. The deep dive is coming to a close. To ensure absolute peak retention for you, the listener, whether you are on the treadmill or sitting in traffic, we are going to execute a rapid-fire mental walk through the wards. I am going to present the clinical scenario or prompt, and you are going to deliver the definitive single-line answer. Are you ready?
I'm ready. Let's walk the wards.
Scenario 1. You need to distinguish osteoporosis from osteomalacia, but the bloods are overlapping. What is your definitive test?
The tetracycline-labeled bone biopsy.
You are looking at a parathyroid profile. You see low calcium and high phosphate. How do you split true hypoparathyroidism from pseudo?
You look directly at the PTH level. Low PTH equals true failure, normal or high PTH equals pseudo.
You are asked to identify the condition on the syllabus that is X-linked dominant.
Hypophosphatemic rickets. You will look for the severely low phosphate.
A patient with Pagets disease presents with a short neck appearance and an isolated high ALP. What is the clinical term for the skull deformity?
Cladibate.
You are reviewing a list of causes for hypercalcaemia. Which drug on the list is the trap, because it is actually a treatment?
Bisphosphonates. They treat high calcium. They do not cause it.
What are the specific mechanisms by which severe long-term steroids wreck bone?
They lower calcium, which triggers secondary hyperparathyroidism. They directly force osteoblasts into apoptosis, and they hit trabecular bone the hardest.
A patient is on zoledronate. What is the precise cellular mechanism of a modern nitrogen-containing bisphosphonate?
It blocks farnesyl pyrophosphate synthase in the mevalonate pathway.
Finally, a patient suffers an ischemic bone event. What is the absolute earliest histological sign of bone death under a microscope?
Marrow changes, specifically the loss of fat cell outlines and the arrival of incoming histiocytes.
And just like that, we have thoroughly mapped out the metabolic bone disease matrix. Congratulations. I want to address you, the listener, directly. This is incredibly dense, highly complex material that often frustrates candidates. But if you hold on to that golden rule reading, those 4 dashboard lights of calcium, phosphate, PTH, and ALP, you realize that all this complicated pathology is just the basic, elegant physiology playing out an illness.
It truly is. Once you understand the underlying cellular mechanism, once you know why the body is reacting the way it is, the pattern recognition becomes entirely second nature. You don't have to memorize 100 different facts. You just have to trace the physiological logic.
But before we let you go, I want to leave you with a fascinating extrapolation to mull over, something that pushes beyond the current textbook. As we consider creeping substitution and how perilously slowly dead bone heals, it raises incredible questions about the future of orthopedics and biology.
It certainly does. We currently spend so much of our pharmacological effort using drugs like bisphosphonates to suppress the mevalonate pathway, to kill osteoclasts, and to artificially freeze the bone in place to stop destruction.
Right. It's a defensive strategy. But imagine a future where we don't just rely on natural, sluggish, creeping substitution to repair osteonecrosis. What if, instead of suppressing pathways, pharmacology finds a way to hyperstimulate a similar metabolic pathway in synthetic osteoblasts? What if we could inject a targeted biologic agent that forces osteoblasts into massive overdrive, allowing us to rapidly seed and rebuild a dead bone scaffold in a matter of weeks rather than agonizing years, long before that weight-bearing joint ever has a chance to collapse?
That would entirely redefine the treatment of a vascular necrosis. We would move from merely delaying joint replacement to actively regenerating the skeleton. It's an incredibly catalyzing prospect.
It's the kind of concept that makes you realize that even with all these textbooks, we have only just scratched the surface of what's possible. We started this deep dive talking about reading dashboard warning lights. Today, you learned how to interpret the codes perfectly for your exam. Maybe tomorrow, you'll be the one designing and building a better engine altogether. Thank you for joining us on this deep dive into metabolic bone disease and pharmacology. Keep that pattern recognition sharp, trust the physiology, and we will catch you on the next one.